Okay, so welcome to this symposium and welcome back to TIO 23. We're going to discuss during the next 45 minutes about contemporary techniques for TAVI in complex patients. So my name is Didier Cheche. I'm from Toulouse, France, and I have the great privilege, and it's going to be fun, to share this symposium with three friends. So we have Kendra Grubb from Atlanta, Darren Milot, from Galway, and Ignacio Amas Santos from Valladolid. So guys, we have a pretty dense but very interesting agenda. I would just like to remind two things. First, thank Medtronic for this unrestricted educational grant, and second, we try to keep everything interactive. This is an online meeting, so please use the chat, post your questions. We're going to discuss that during these 45 minutes, so feel free to jump in with any kind of comment using the chat, and Kendra, Ignacio, and Darren and myself, we will try to address your questions. So you've seen the objectives. We will try through the lectures and discussions to try to understand why the choice of the first valve matters for young patients. We will try to understand more about the currently available data for TAVI durability in younger patients, discuss how we can implement the Cusp overlap technique into our daily practice to improve the outcomes for this patient, and at last, younger patients, most of the time equals bicuspid, so what are the outcomes and how can we optimize everything for bicuspid aortic patients. So this is the menu. Once again, feel free to come up with any kind of questions, but without further ado, I'm going to hand over to you, Kendra, for the very first talk about the choice of the first valve.
Wonderful. This is a increasingly common question, considerations for the first valve implantation. And this is becoming more of an issue as our patients are getting younger. Here are my disclosures, and more low risk. So low risk patients, who are they? Well, the typical patient with severe symptomatic aortic stenosis showing up in the valve clinic has changed dramatically over the years. If you're 80, you're getting TAVR. We don't even really need to discuss you unless you have anatomic reasons that you're not a candidate. But now the greatest increase in patients in this particular registry are in patients less than 65 years old. And so our low-risk patients may need 2, if not 3 valves in their lifetime. They are active, they want to feel better, they want to be able to chase after their grandkids and do all of their activities. Many of them are still working, and they have a really long time to live. And so because of this, we have to be very, very conscientious of that first valve choice. So here's an example of a patient I saw recently, 70-year-old female, New York Heart Association class 3 symptoms. She actually had known about her aortic stenosis for a number of years. She's been followed with serial echoes. She's active, she plays tennis, she likes to babysit her grandkids, and she literally can't do the things that she wants to do anymore. And for her, getting back to playing tennis, that's her primary objective. She really doesn't have much in the way of other comorbid conditions. She has AFib and she's on Eliquis. Her creatinine's a little elevated, but she's low risk for surgery. And here you can see a heavily calcified valve with a mean gradient in the 50s. And when we assess her CT scan, you see she's got a relatively small annulus. The perimeter is 67, an area that would size for a 20-millimeter sapien if we were to put a balloon expandable valve. And when I think about a surgical valve, without a root enlargement or replacement, this will likely be a 19, maybe a 20-millimeter valve. So not necessarily good choices. So the supraannular valve may be better, as we'll be able to get a much larger valve in for this particular anatomy. Sinus of Valsalva is adequate. STJ looks fine. Ascending aorta is not dilated. Coronary height and sinuses are very adequate. And her angles are favorable, and she had excellent transfemoral access. And so when we think about this patient, what's the right thing to do? Well, when I'm talking to this patient, not only does she want to be active, but there are things that she wants. She says, I want to play tennis again. She says, I don't want a pacemaker. And she says, I don't want my chest cracked open. And so we had a lengthy discussion about what her choices would be. And ultimately she says, well, what's the best valve for me? And I had to be honest with her. I don't know what best is, but I do have some data about what I think is probably going to be the valve that lasts the longest. So the 5-year incidence of bioprosthetic valve dysfunction, or BVD, in patients randomized to surgery or TAVI, an insight from the CoreValve US Pivotal and TAVI trials, was presented at CRT in February by Dr. Yakubov. And this gives us some insight into this. Prior to this, Dr. Reardon had presented this data at ACC, specifically looking at structural valve deterioration, and showed that there was decreased structural valve deterioration out to 5 years in the patients who had CoreValve or Evolut compared to surgery. And this was even more pronounced in patients with small annuli. So already we saw that there was a benefit for TAVR in women with small annuli. Going to Dr. Yakubov's data, this would evaluate the incidence, outcomes, and predictors of long-term valve performance, specifically BVD, comparing self-expanding supraannular valves to surgery. You can see that these patients are much older than my patient. And so maybe my patient, we need to think beyond just this data, but this will give us a pretty good indication. Again, significantly lower rates of BVD with CoreValve or Evolut compared to surgery out to 5 years. And when you look at the specific reasons, it was not only structural valve deterioration, but also patient prosthesis mismatch. So that first valve really matters. If I put in a 19 or even a 21 millimeter surgical valve, not only does it not give me a large valve to build on, but it also sets this patient up for early failure. Significantly lower rates, especially in the small annuli. So when I'm talking about my patient, my 70-year-old female with small annulus, there's even more reason to consider TAVI first with an Evolut. This is a summary, but the difference in valve performance, again, driven by 2-fold lower structural valve deterioration and 3-fold lower severe patient prosthesis mismatch. Newer data just recently 2 weeks ago presented from the low-risk study. Now, I wish that when she asked the question, which is going to last longer, I wish I could tell her I knew the answer, but I don't. The surgical data is not randomized. It's very skewed toward a frequency of reintervention as opposed to a true incidence of failure. So the 2 low-risk trials will give us the most information about the durability and long-term outcomes of transcatheter and surgical valves. Dr. Flores presented this just 2 weeks ago at ACC, looking at 3-year results of Evolut. Now, these patients, a little closer to my patient's age, still a little bit older, but pretty much represent the type of patient that she is and what she should expect. Primary endpoint, all-cause mortality or disabling stroke. Notice that there is a decreased hazard ratio for TAVR versus surgery. Now, this did miss statistical significance, but still very impactful. All-cause mortality or disabling stroke, no major difference. Valve performance, excellent, with lower patient prosthesis mismatch. Hemodynamics at 3 years, significantly better mean gradient and EOA with TAVR at all time points out to 5 years. And so at 3 years, the rate of all-cause mortality or disabling stroke after TAVR with the Evolut valve compared favorably to surgery. Patients have better hemodynamics at 3 years and very low rates of valve thrombosis. So what the patient wants, again, she wants to play tennis. She doesn't want to have a pacemaker, and she doesn't want her chest cracked open. And so for this patient to be active and also to be thinking long-term, a supraannular valve that we could then put a valve inside would be an excellent choice for her at this stage in her life. A couple other features, paying attention to cusp overlap. I am privileged to be part of the Optimized Pro trial, and we're specifically looking at the cusp overlap technique to optimize implantation in order to avoid permanent pacemakers. And using this technique, we have decreased the pacemaker rate to single digits in the North American cohort, and subsequently also noted that there were no patients with moderate or severe paravalvular leak. We also have the ability for commissure alignment. So if she needs coronary reaccess, we're able to align the commissures, and with the newest FX system, that's over 90% of the time that this can be achieved. So how do we do that? We introduce the delivery system with the flush ports at 3 o'clock, confirm the hat marker is on the outer curve as demonstrated here. We then advance into the ascending aorta, again, making sure the hat markers are now on the outer curve. Cross in the RAO position and start at mid-pigtail. This is the FX valve. You'll notice with the depth and commercial dots, they're at 3 millimeters, so it can be used for depth, but also it's going to achieve commercial alignment. After our initial flowering, we confirm in the non-coronary cusp our depth of implant. Here, probably a depth of about 1 millimeter. I then roll to my left and then check the left, deploy to 80%, ignoring the depth markers at this point. At the 80% point, I again assess my depth in the non-coronary cusp. My goal is 3. Roll LAO, assess the depth in the left position. Here, I'm probably a little bit deeper. I do expect the valve to settle in slightly. And so I think this is probably an optimal position. Wire back to the nose cone. A slow final release. No tension on the system in this particular case. And a final depth of implant, about 2 on the non and on the left coronary cusp. Here's our final result. The valve is nice and high. There's no paravalvular leak. I have a 26 millimeter evolute and a gradient of 5. And she did very well and went home the very next day. So with that, I will kick it off to my colleagues. Thank you.
So thank you very much, Kendra. So that was a very thorough review of the literature about durability, hemodynamics, and contemporary techniques for younger and lower risk patients. When we talk about low risk patients, there are low risk and lower risk patients, and the age plays a role. If we take, for instance, the registry about Martinson, about a very large cohort of surgical patients at low risk, when you reach 70 years old, you have a life expectancy of about 10 to 12 years. So do you think that there is a cutoff in terms of age below which you wouldn't offer TAVI, or do you think that the durability that we have with the device currently available TAVI devices, particularly the self-expanding supraannular ones, matches the expectations of your lower risk patients, the ones that you are treating now?
Well, I think that we're in kind of this messy middle. We don't have long enough data to really answer the question of how durable these valves are going to be in younger patients. And I'm not going to even use the word low risk. I'm just going to say younger. So the guidelines differ. In the US, the cutoff is 65 for TAVR versus SAVR having equipoise. And in Europe, as you're well aware, it's 75. What's the reality? I think that a 70-year-old certainly should be offered TAVR. When we get down below 65, that's where I start to have the biggest concerns, because I have to be planning for multiple valves. And with a biologic valve, even if I start with surgery, how am I going to be able to place another valve inside and maybe even a third? And so now there's all these different strategies of TAV, SAV. Well, nobody's going to want to be having their sternotomy in their late 70s or early 80s. And so I do think there's a cutoff. And I think that the guidelines have it right. 65 seems reasonable to me. There's still risk that they're going to need a sternotomy at some point. But when my patients come in their 50s, I really have to be thoughtful about what's best for them at that point in their life, knowing that that is not going to be their last valve. And if we start doing TAVRs in 50-year-olds, we have to be planning for the sternotomy.
So thank you. This was a very clear answer, Kendra. So Ignacio, one of the goals for younger and lower risk patients is to make sure, as for Kendra's example, that the quality of life and the ability to exercise is going to be maintained for the patient. So the hemodynamics play a role for this matter. So we've seen that the device that was presented within these trials, the core valve evolute platform, outperforms the surgical devices that were utilized. Do you think that if we take, for instance, a small anatomy, there is a difference in terms of self-expanding intraannular or self-expanding supraannular devices. According to your experience, have you seen something different?
Actually, I like very much the question, because I think this is a crucial factor. In Southern European countries, patients are smaller. In Latin America, patients are smaller. In Asia, patients are smaller, more bicuspid. There is also more rheumatic disease. So not only age determines the risk. Maybe we have a relatively young patient with a very small annuli. There, the supraannular technology, I think, plays an incredible role in the future prognosis of the patient. So very important factor.
So thank you. And Darren, there is another question coming from our friends connected online about if we focus on lower risk and younger patients, do you have any specific antithrombotic regimen that you propose to these patients, or do you apply the same cuisine whatever the age or the risk profile of the patient is?
Yeah, it's a great question, Didier. I think we've all moved away from dual antiplatelet therapy towards single antiplatelet agents. And we've done that in the knowledge that when we've looked at dual antiplatelet therapy or the addition of a novel anticoagulant, that we've had higher rates of bleeding. But these studies largely included patients who were in their 80s, who clearly have a much higher bleeding risk. So it is quite possible that in younger patients who have a lower bleeding risk, that novel antiplatelet strategies or anticoagulant strategies could have a role to play. I think we need to consider what are the benefits and what are the risks of a more potent antithrombotic strategy. Clearly, the risk is bleeding, but the benefit remains unclear at the moment, because if we think about valve thrombosis or HALT-HAM, subclinical leaflet thrombosis, we know that anticoagulants can reduce the risk of this, but whether this imaging finding truly is associated with adverse events, be that TIA, stroke, or indeed later valve deterioration, is unclear. So I think we have a little bit more to learn before we would tailor strategies for individual patients. In the coronary field, this obviously took a long time to drill down and find the right strategy for the right patients, but I think in due course we will have different regimes for different patients.
Okay, thank you very much, guys, for this very interesting and important discussion about the impact of the first VACHOs for these younger and lower risk patients. So let's now dive a little bit more into the technical aspects of the procedure. And Ignacio, could you drive us about what you've learned and what you are developing in terms of commissural cusp overlap technique and commissural alignment for your patients?
Yes, sure. Thank you very much. So the proposed heading for my presentation was right place every time. In TAVI, like in life, we cannot always be in the right place every time, although the attendees today are in the right place. But with TAVI, in the couple last years, we have improved really the place where we are implanting our valve. How have we done this? By two ways. First, cusp overlap, that has been previously briefly explained by Kendra before, and second, by commissural alignment. What about cusp overlap technique? What we are trying to do with this technique is isolating the conduction system in one side of the anatomy that we control very much to avoid prolapsing with the struts of our system in that particular region. For that, it's crucial to have a clear understanding of what we are doing, and the imaging analysis, which is quite simple but has to be meticulous, can determine perfectly where we can start implanting and how we will follow the implantation with particular steps. These steps have already been described, so I will go very quickly through this part of the presentation. First, we will need to position in cusp overlap our radiopaque marker at the level of the mid-pigtail. So we can start opening the valve and prolapsing between 1 and 3 millimeters into the LVOT, no more than that. If we are beyond that, we can recapture and reposition. During this step, we can do rapid pacing to avoid further movement of the system. We need to have the wire well in the ventricle, but in the next stage, we will remove partially the wire to avoid any pushing backwards of the delivery system. And for the final release, once we are happy with the position, apart from removing the wire, as I mentioned, we would perform a gentle pushing of the delivery system to avoid any final movements of the valve. And this is nicely implanted with our target of 3 millimeters. It was also mentioned the Optimized Pro study with a cohort of 400 patients, where we could find, very interestingly, that not only Cusp overlap is safe in terms of valve migration, valve embolization, or need for reintervention, but also we were able to reduce below 10% the rate of permanent pacemaker. This was also validated by TVT registry, which along the last few years we have seen how to reduce the rate of pacemaker. In a recent publication in my particular environment, we could see also a clear decrease in the rate of pacemaker once a commissural overlap technique is used. And what about commissural alignment? Well, the main target of this strategy is to preserve coronary access. This is what we know. There are some factors that we believe, like there are no adverse events related to the manipulation of the delivery system inside the patient. Anyway, the proposed strategy currently is to advance the delivery system in a fixed position at 3 o'clock. Of course, there is a lot of research suggesting that we can modify the position of the delivery system inside the patient, but we need more data regarding that. We believe that there might be better gradients, and this be particularly important for intra-annular devices, maybe not so important for supraannular devices. These gradients are key, and also if there is any potential impact in regurgitation in terms of durability. And we know that if we need TAV in TAV in our low-risk patients, this strategy can help us to simplify our lives and improve the prognostic of the patient. There is also some research regarding the use of patient-tailored alignment in some patients. This is based on the analysis of the CT of our patients, where we can try to target a specific position of the delivery system when introduced in the patient by simply simulating how the valve advances in the patient and rotating in the simulation the valve to see how we can align better. In this case, for example, this was inaccurate. It was a rotation counterclockwise 50 degrees. And then we just need to advance the delivery system exactly in that 50 degrees counterclockwise orientation. But this strategy have been tried with other self-expandable systems, also with Evolut, and validated. For balloon expandable, it's a little bit more complex because we need to rotate while we are crimping the valve and not by rotating the delivery system. The preliminary results that we have with this kind of tailored strategies are quite good with minimal misalignment. But of course, this is a more complex strategy than advancing the delivery system at 3 o'clock. When we do this simplified strategy, we can simply verify that the heart marker is in the outer core of the aorta as we advance, and that when we are in cusp overlap view, the heart is center front. We can verify that it's at the front by comparing with the 3 cusp view. Once we have the right position, we will implant the valve and check that we have been correctly aligned by checking that we have a lateral view of the C pattern, like you can see in the slide. This is important. We all know the reaccess study. When we don't have correct alignment, it's more challenging, even impossible in a few proportion of patients to reaccess the coronaries. But what we wonder next is if it's enough with aligning the commissures to get a correct access to the coronaries. And we know that no. The reason for that is that sometimes the ostium of the coronary is not central, but it's moved to one of the sides of the sinus. And this will make that even if we have a correct commissural alignment, and in the future we need to perform a basilica for a second procedure, this might not be successful. So this tailored approach of the commissural alignment or coronary alignment might be particularly useful when we are facing patients with eccentricity of the coronaries, which is not rare. If you see the red line is the center of the sinus, and you can see that most of the right coronary arteries are not at the center of the sinus, which is not true for the left. Left, most of the cases are at the center, but still we can see some variability. So for this particular setting of patients, it can be useful. In the figure in the left, you can see commissural aligned patients where we can still have some overlap of the commissural post with the coronaries. But if we use a tailored approach in those with eccentricity, then there is no overlap at all of the commissural post with the coronary ostium. We are performing a trial now to check if this works. One important aspect was if this also has a clinical impact in gradients and regurgitation, this commissural alignment. We know for previous research that with balloon expandable, there might be an impact, which is significant, but with supraannular, maybe it's not so important. In this ongoing research with more than 500 patients, with 38% of them with a strategy for commissural alignment, either 3 o'clock or patient-tailored specific strategy, we achieve 73.5% of non-normal alignment when we do a strategy. If we do not do any kind of a strategy, this is below 50%. So at least we are improving slowly this rate of commissural alignment. We have already data in more than 500 patients at 1 year follow-up, and apparently supraannular devices don't have an impact in gradients. But when we check the degree of regurgitation, we can see that those patients with no or mild misalignment have a degree of aortic regurgitation that remains stable in the first year, but there is a trend to increase in the rate of regurgitation in those with moderate or severe misalignment. And if we check only those with severe misalignment, then this is significant when we follow the patients at 1 year follow-up. So something's happening here. Maybe there's no impact of misalignment in gradient, but it's a suggestion that there might be an impact in regurgitation. So to summarize, commissural alignment might be particularly useful for coronary reaccess and TAVI in the future, but there is also an hemodynamic impact in paravalvular and central leak in our patients. We still don't know if there is another impact in terms of shear stress or valve degeneration and longer-term follow-ups. My final comments: Cusp overlap has helped us to reduce the need of pacemaker. Commissural alignment has a clear impact in hemodynamics that in supraannular valves might be particularly relevant in the progression of aortic regurgitation. We also know that commissural alignment allows easier coronary reaccess, and in those with coronary eccentricity, a patient-tailored approach might be the best alternative. Thank you very much.
Thank you very much, Ignacio, for this very interesting talk. So we now understand clearly that the Cusp overlap technique is the way to go in contemporary practice. First, to decrease, as you've said, and as Kendra has mentioned, the risk of pacemaker, but as well to make sure that we have a nice commissural and potentially in the future proper coronary alignment for our patient with a potential impact on regurgitation. Question for you, Ignacio. We've seen some hints about futuristic TAVI. Do you think that in the future we could envisage to have some kind of robotic assisted procedure for perfectly tailored commissural or coronary alignment for our patients? Do you think that this is something that could be envisaged in the future, robotic TAVI?
I think there is a lot of research in that direction. But I also think that we should focus our efforts in the planning of the procedure so that correct analysis of the CT, there is a lot of information in the CTs, might simplify what we are doing to the patients without the need to increase the cost of the procedure with more complex technology.
Thank you. Kendra, I have a question for you. So we understand that higher seems to be better for our patients in terms of pacemaker, regurgitation. We are talking about low-risk patients. Are there a situation in which you think that if you get higher, this may have an impact on a future TAV procedure? Do you have examples in mind, or is this something that you don't consider at all? You put the device as high as possible in every single patient?
No, I don't put the device as high as possible, especially with supraannular valves. We certainly understand that the higher the valve is, the longer the leaflets are going to reach the STJ. And so if we're talking about lifetime management, we have to be thoughtful of the first implant, not only in terms of the things I mentioned, but also in planning for the second valve. And so my goal is not really 0. My goal is 3 millimeters, and that's going to be able to facilitate coronary reaccess and TAV in the future in most patients. Now, I was fortunate to be part of a team that analyzed all of the CTs from the low-risk trial, and about 80% of those patients will have easy TAV options. But the higher the valve is implanted, the more problems you're going to have. And so there are going to be patients based on their preoperative CT that either you choose a different platform or you land the valve a little bit lower. And so that risk of pacemaker versus redo TAVR, we have to be thinking about that for every single implant.
Makes sense and very clear. So Darren, a question for you coming from the audience about when we have challenging coronary cannulation. Do you have a couple of tips and tricks that you could share with our friends connected online?
Yeah, good question. It doesn't happen very often, but it certainly can, and we've run into trouble in the past. I think the first thing is perhaps to review the TAVI implant. You can understand, given the various imaging or implant views are used, what do you see in each? You can understand whether you've got commissural alignment. And it's not unusual that we would start a PCI, for example, through the side of a core valve with an aortogram with a pigtail to try and understand where the coronary ostia are. And probably the best starting view with that is some form of eleocranial, where you're going to see the ostium of the right coronary artery and the ostium of the left main reasonably well. I think if it's a small anatomy, sometimes coming from the left radial or the femoral might be a little more easy than coming from the right radial, which would be our default approach. Starting to take a smaller catheter, so half a size smaller, again, particularly in those smaller anatomies, and very often trying to use the wire to get you to the base of the sinus to exit the side of the valve. Again, of course, using adjunctive technologies. So, for example, having a wire that you can try and get out the side of the valve. Fairly liberal use of guide extension catheters can be helpful. And one tip I've recently learned, actually, from some work on the bench, is sometimes using a very elongated catheter like a JL6 can actually get you out of the side of the valve quite nicely. So I think there's a bunch of tips and tricks, but it really depends on the individual's patient's anatomy. Final thing is that we try and concentrate that expertise in the hands of a few. So if there's a patient who needs the PCI post-TAVI, they tend at the moment to come back to people who do TAVIs rather than people who don't. And the same for coronary angiography. But of course, we have a need to teach these techniques to the wider interventional community. But I think we're going to have lots more opportunities as our patients, as we treat younger patients.
So thank you for this, for sharing these tips and tricks. There is a question concerning bicuspid aortic valve. So this is a nice transition to you, Darren. Could you tell us how to optimize the outcomes for bicuspid aortic, for TAVI in bicuspid aortic valve patients?
Sure will. So if I can get the slide deck up, would be great.
I'm sure you know your talk by heart, so you can do it like that without any slides.
Absolutely, no problem. So thanks for the invitation, guys. These are my conflicts of interest. And first, I wanted to just discuss some of the issues with bicuspid challenges. So, of course, we have a raphe that is usually calcified. We've very often got severe leaflet calcification, particularly in those younger patients. that calcium is asymmetric, and its distribution is different to that of tricuspid aortic valve stenosis, both in terms of its leaflet distribution of the leaflets and also the height of the calcium. Commerce-pleural fusion, aortopathy, and concomitant aortic incompetence are also issues. And if we look at those first 4 or 5 issues, they really all contain the word calcium. So calcium really, for me, is the difference in the majority of cases with bicuspid that leads to the challenge. I mentioned that the distribution is different, and that's because in tricuspid aortic valve stenosis, the calcium tends to be at the base of the sinus and the tips of the leaflets. So in terms of sizing, you do it at the base of the sinus and the tips of the leaflets. The calcium there doesn't matter so much because it gets extended backwards into the sinuses of Valsalva. On the other hand, in bicuspid morphology, the calcium tends to be in the mid portion of the leaflets, and therefore the valve design and the position of the valve has to be able to expand this in an area that's not really designed for that technique with contemporary devices. We're getting better at understanding calcium assessment and understanding the distribution of the calcium, the severity of the calcium in this patient, very severe calcification, as you can see, and we can quantify that and therefore edit our strategy according to the individual patient anatomy. And Didier, you published this very important data looking at these configurations, tube, flare, and taper, which attempt to help us really understand where is the most severe piece of calcium and what is the configuration that we have. Having said that, maybe the limitation with this excellent manuscript is that you're looking at the intercommissural distance at 4 millimeters, and we know very often the calcium in bicuspid lies higher. It lies between 6 and 8 or even 10 millimeters high. So understanding what is above the level of the annulus is extremely important when considering sizing for bicuspid. We do, of course, have people who prefer annular sizing, people who for example, like intercommissural distance, and also those that prefer superannular sizing, be that a spline, be it a Casper or a Lyra method. But ultimately, we really don't know which of these methods is the best or the most appropriate. And so we tend to measure all of them for each patient and try and figure out which is the right one. Maybe the art of medicine is still relevant here. But the difficulty with bicuspids clearly is that there's no one size that's going to fit all. These are all some of the bicuspids that we've treated, and you can see how different in terms of calcium distribution and leaflet morphology these cases are. There are very easy bicuspid cases, and there are those that are much more challenging. A quick review of the data. We know that from a historical point of view, TAVI outcomes were inferior in the early bicuspid days. They seem to have improved, but if we put all of that data together, we still seem to have more paravalvular leak, more cerebral ischemic events, and in the case of balloon expandable valve, more annular rupture in bicuspid compared to tricuspid. Raj Makar and Sungha Nyun did this really important work identifying patients who are at increased risk of an adverse outcome, those with a very calcified raphe and above the median in terms of leaflet calcification, had 3 times higher mortality, 5 times higher risk of aortic root injury, and more PVL. However, this only applies to balloon expandable valves. I think Medtronic have done really stellar work in terms of getting some prospective data, and we do see encouraging data, I would say, in the bicuspid space. This is mortality or disabling stroke in the low-risk patients with bicuspid disease. But again, bring your attention to the rate of any stroke. 4% is probably just too high. And particularly when our surgeons are agnostic to valve anatomy, it doesn't change the surgical outcome. So we need to be cautious when addressing these patients. So how do we do it? Here's a case example. This is a Sievers type 0 bicuspid we did a couple of weeks ago. Very severe aortic valve calcification with a perimeter at the level of the annulus of 97. So right on the tips of the sizing algorithm. Having said that, as we scroll through this, you're going to see these 3 or 4 bars of calcium that extend from the mid portion of the leaflet right into the area where the valve would be housed. And you can see those bars of calcium on the 3D reconstruction. Note that the LVOT perimeter here is even larger. Again, it's 102 millimeters. So what do? We do all of those sizing algorithms that I mentioned. Intercommissural distance, 27. Perimeter, a supraannular spline is what we do, so 77.9. And ultimately, our strategy was to to do a really good pre-dilatation and implant a 29mm Evolut Pro in this very large annulus, but much smaller supraannular space. A brief word on the pre-dilatation. You're going to notice here that we bring the eye of the Trimencio wheel around to find the largest piece of calcium, where very often this is the raphe, and we find a specific view to do the pre-dilatation, and this allows us to be very sure that the balloon has actually opened the anatomy before we put a valve in there. In this case, that was, I think, LAO 35. This is the second balloon we opened with a 25. We didn't open it properly. This is now a 26mm balloon that we used, and still you can see some waste on that device. And then the steps that Ignacio told us in terms of the cusp overlap technique, usually an REO caudal implant. We start mid-pigtail. We implanted about 1 to 2mm, particularly in bicuspids, maybe 1 millimeter or 2 higher. And then when we're doing our final release, we're very cautious in terms of pacing on the LV wire. You can see there's some waste on the balloon here in that area that we spoke about over in the LAO image. And therefore we did a post dilatation with the 26mm balloon. And this is the final result. No gradient, no PVL, happy patient who goes home the following day. So with that, Didier, I'll hand back to you, and of course, happy to take any questions that the online audience may have regarding bicuspids.
Nice and comprehensive review of what we know about bicuspid. We are running a little bit out of time, so maybe Darren, one quick question to you. What are the anatomies, examples of anatomies that you wouldn't treat? You wouldn't do TAVI in terms of bicuspid?
Yeah, I think it very much depends again on, I don't think we can just look at a specific anatomy, in that if you've got a patient, for example, who is extreme risk, declined by surgeons, then for me, it doesn't really matter. I think you can achieve a good outcome in the majority of patients. But where the patient does have a good surgical option, for me, a patient with aortopathy, of course, a patient with very severe LVOT calcium, and in terms of bicuspid, the very long raphes that extend, 30, 40, 50% the width of the annulus, they are very challenging to treat. And the Sievers type 2 bicuspids, where you've got 2 raphe with extensive calcification, they're the challenging ones for me, Didier.
Okay, thank you. So I would like to thank you guys, Kendra, Ignacio, Darren, because thanks to you, we've understood throughout this symposium why the choice of the first valve matters for our younger and lower risk patients, because of their longer life expectancy. They are more active, so in terms of hemodynamics, preventing pacemakers, regurgitation is very important. We've understood how the technical refinements, implementation of the cusp overlap technique with the commissural and potentially in the future coronary alignment is going to play a positive role in terms of outcomes, improving furthermore the outcomes for our lower risk patients. And at last, as we're going to meet more bicuspid patients, how we can properly select these patients and treat them to get nice clinical outcomes. So thank you guys for sharing your knowledge. Thank you to you connected online for coming with your questions and comments. I would like to thank Medtronic for providing this grant for this symposium. And stay tuned, the main program is resuming at 6 p.m. or 1 p.m. ET. It's going to be about key issues with TAVI. So thank you for attending this symposium, and I wish you the best for the rest of the program. Thank you, guys.